Right, good evening to everybody out there. It's 6 o'clock. Welcome to the latest installment of the Faculty of Dental Surgery webinar series. My name is David Morris. I'm a consultant orthodontist here in Leeds. I'm also a FDS board member and chair the Clinical Standards Committee at the college. Before I introduce this evening's speaker, I have a few housekeeping matters to let you know about. First of all, this webinar is being recorded and will be available for viewing in a week's time on the faculty website. Your CPD certificate, very important obviously, for tonight's meeting will also be issued within the next week. And importantly, for tonight's presentation, could you please forward any questions during the webinar via the questions box, and we will do our best to address them during the final 15 minutes Q&A session. So thank you for that. So tonight we are narrowing our aperture and focusing our lens, forget what I did there, on a topic very pertinent to all dental clinicians and educators. Dental photography, whether it be part of the patient's clinical records, possible material for lectures or presentations to help demonstrate the patient's progress, or for good old medical legal reasons. This is a subject that has a shared interest within the dental and medical profession. This evening, it's my great pleasure to introduce to you our speaker, Mr. Naeem Adam. Naeem is currently midway through his post-CSST, that's the Senior Registrar in Old Money, orthodontic training in the Yorkshire region. For those of you who don't know Naeem, he's fast becoming the David Bailey of the orthodontic world. If one of his keen-eyed photographs hasn't adorned the front cover of Dental Update or Orthodontic Update over the last couple of years, then it's not been an issue worth publishing. Naeem's the sort of guy you don't stand still around for long, and never ask him to show you his holiday snaps unless you've got a spare 3 hours. So without further ado, I would like to turn the spotlight onto Naeem and invite him to give us his presentation entitled Dental Photography. If a picture paints 1,000 words, then could a photo say it all? So with that title and the immortal words of Mr. Telly Savalas, it just leaves me to say, who loves you, baby? Take it away, Naeem. For those of you under 40, you don't know what I'm talking about, just Google it. Okay, thanks, Naeem.
Thank you, Mr. Morris, for that introduction, which I think will probably never be topped or imitated for as long as I'm practicing. I'm certain of that. And also thank you for the title of the presentation. I think it fits beautifully. So as Mr. Morris said, my name's Naeem. I'm a Senior Registrar at the Leeds Dental Institute, and thank you to you all for attending this lecture on a Tuesday evening about photography when you could be doing so many other things. So we're going to start off with a list of the objectives. So what I want you to do at the end of this presentation is to have these objectives fulfilled, but more than that, I'd quite like you to take away 3 things really that you've taken from this presentation that you think you could apply to your own photography, that you think would improve it. So 3 actual tangible things rather than an abstract achievement of aims and objectives, which I think can be a bit nebulous. But I'd like you to appreciate the value of photography, both clinical and non-clinical. I'd like you to understand how to take extraoral photographs and how they might be improved with the use of off-camera flash or a slave flash. I'd also like you to understand how to take intraoral photographs and optimize retraction, because that's often the key to good quality intraoral photographs. And I'd also like you to have some slight appreciation of the information governance implications of photography and the photographs we take. And on that point, the appropriate consent for all the patients in this presentation has been obtained, and as well as the assistants that have also lent their help to this presentation. I've got the WhatsApp conversations to prove it. So let's start by talking about the basics of photography and how photographs are made. So this is some theoretical stuff, and I think it's important to have an appreciation of this so we know why we're changing the settings in the clinic when we do. So the basic equipment that we need to take a photograph consists of 3 items. Firstly, you have the body, the camera body, you have the lens, and you have the flash. Now, this camera here, the Canon 70D, is one that I use often in the various places that I work, and it's nearly 10 years old now, and it can be picked up for about £260. And really, it takes some fantastic quality photographs, and it does the job absolutely serviceably. So you don't need to spend a fortune to take good quality photographs. What you also need is a macro lens. Now, what you see in the middle there is a macro lens, and this allows you to take magnified and zoomed in photographs with exceptional detail, exactly what you need for dental photography. And because we're working in the dark confines of the mouth, what you also need to be able to do is to illuminate the teeth, and for that you need a ring flash. And you'll notice that these three components are all from the same manufacturer, and really in the world of photography there's two principal manufacturers, maybe three, but Canon and Nikon really have led the way in dental photography, and you're either a Canon person or a Nikon person. And I personally prefer Canon, but my piece of advice would be, if you're going to buy from one manufacturer, you should try and make sure that all three of these components are from the same manufacturer, because they talked to each other in one way or another, and it means you get better quality photographs. I would avoid mixing and matching, because the end result doesn't tend to be as good. So how do these cameras work? Well, these cameras, they have a mirror inside them. So at the center of this image, you can see this mirror here, and that's essential to how these digital cameras work. So light travels through the lens, obviously. It then hits this mirror and is reflected around then through the viewfinder. And this is essential because what you see through the viewfinder is what you would see through the lens. And so what you see through the viewfinder, if you've set the camera up correctly, is the photograph that you'll take. And so if it doesn't look right in terms of the patient's position or the composition, when you've set the photograph up ready to be taken, it won't look right when you press the shutter release and take the photo. So the first tip is, make sure the picture is composed absolutely perfectly before you take it, because what you see is what you get with digital cameras. So how do these cameras take light and produce a photograph? Well, if you look at the image on the left here, you can see that there's a lens and light travels through the lens. And then there's this thing called an aperture, which controls how much light is allowed through onto the image sensor. And the light falls on this sensor and creates the photograph. So that's the one way in which light is controlled in order to make a photograph. The second way is that this shutter here, which either allows light to hit the sensor or prevents light from hitting the sensor, can be opened and closed. And when you open it, that's when the photograph is taken. So obviously how long the shutter is open for will have an influence on the sort of photograph that's taken. So we've talked about two things there: the size of the hole through which light is let in, how long the shutter is open for, and the third thing is how sensitive the actual sensor itself is to the light that's allowed to go through the camera. And it's these three things, when combined together, that control the sort of photograph that you get. And the sensitivity of the sensor is called the ISO. And the higher the ISO, the more sensitive the sensor of the camera is to light, and the less light you need to take a photograph that is bright enough. And that's also called being correctly exposed. So the more sensitive the sensor, the less light is needed. But also the more sensitive the sensor, the more the image degrades. So although you need less light to get a good photo, the photo that you get can be worse if the ISO is too high. The shutter speed, as I mentioned, controls how long light is let onto the sensor. So if light is only let onto the sensor for a brief fraction of a second, and these numbers here, you can see this 1/400th of a second, that's a tiny fraction of a second. What that does is it freezes whatever's going on in front of the lens. So if you've got people moving quickly, or you've even got, cars going past fast, what it does is it captures that action and you don't get any blur. But the longer that shutter's open for, the more blur that you get in the photograph, because the more light that's let through, but also more things have happened in the time that that shutter's been open. And finally, the third thing, the aperture. The wider the aperture, and this can get a little bit confusing, it's illogical, it's the opposite of what you might think. The wider the aperture, the smaller this f number, which is a measurement of how wide the aperture is. So very wide openings for the light, very wide apertures, have a very small f number, and very narrow openings, very narrow apertures have a very large f number. And the smaller the f number, the smaller the f number, the larger the opening, and the more contrast you have between what's in focus at the front of the picture and what's in focus at the back of the picture. So let's see what that looks like. So here you can see on the left a low ISO, so you've got a correctly exposed image, and on the right you've got a high ISO, but you've got all this graininess, this noise. For dental photography, we keep the ISO at 100. So we keep the camera as least sensitive to light as possible, but we control the light and we produce a lot of light using the flash and the other factors. Now, shutter speed, here a very quick shutter speed, 1/500th of a second, has frozen that windmill in time as it's been spinning, and a 2-second shutter speed has given this blur effect, the motion blur. And you might think, well, the patients don't move around, do they? And we don't take photographs of them biting together or eating. So why does the shutter speed matter? Well, it matters because the patient might not be moving very much, and the teeth certainly don't move when we take photos, but the cameras that we use are handheld. And inevitably, irrespective of how steady your hands are, there'll be a tendency for them to shake. And so if you have a shutter speed that's too slow, the photographs will be blurry. But what you want is a shutter speed that's sufficiently fast to avoid any camera shake being captured in the image and the image becoming blurry. But because the shutter's only open for a fraction of a second, you need lots of light to get into the sensor in that brief period of time. And that's why we use a ring flash, to give us all the light that we need. And finally, the aperture and the f numbers are what we control and change most frequently in dental photography. So the other two components of the exposure triangle, the ISO and the shutter speed, we keep pretty consistent. However, we open and close the aperture. When we're taking extraoral photographs, we want a wide open aperture with a narrow f-stop, with a low f-stop. And what this does is it allows more light to enter the camera when the ambient surrounding doesn't have that amount of light, and it allows us to take a correctly exposed picture of the patient. Now, in portrait photography, a low f number, a wide aperture is prized because, like in this top left photograph here, it gives you this nice contrast between the subject, the person that you're taking a photograph of, closer to the camera, and the blurry background, which is what you need. And in intraoral photography, when we're taking photographs of the teeth, we want a very narrow aperture, a high f number, because we want as much of the photograph in focus as possible. So front to back, from incisors to second molars, we want to see as much of what is in the picture in sharp focus. So we use a narrow aperture. Then you can see in these photographs, as the apertures change from f3.5 to f5.6 to f10, the shutter speed has had to slow down. So the shutter has been left open for longer, because obviously if you're closing the opening through which light can travel, and you want the same amount of light at the other end, you've got to have the opening open for longer. And as you open the opening, you can allow light to pass in over less time because more of it can get through this wider aperture. So what does this mean in the clinic? So as I say, for portraits and for intraorals, we keep the ISO and the shutter speed the same. And that if the image you take is too dark, you decrease the f number, and if it's too bright, you increase the f number. And diffusers, they're a popular addition that more and more people, especially on social media and Instagram, are using to improve the quality of the photographs. because the ring flash can give a lot of reflections, this diffuser, which goes over the top of the ring flash, and you can get this for £60 here. And I don't work for big diffuser, I don't make any money over how many diffusers are sold. But what it does is it gives more character to the teeth and the soft tissues. What does that look like? Well, on the left, you've got a photograph taken without a diffuser. On the right, you've got one taken with. And on the right, the image looks drier, and it can, for some people, appear to have a better quality. And it looks drier because saliva reflects light. And if you attenuate those reflections, things appear drier. So some people prefer that look, and that's what diffusers do. But they won't make a terrible photograph good. They'll probably make a very good photograph better. And if the patient's got a lot of characteristics in their teeth, like hypomineralization or fluorosis, it will really bring out that detail. So unless you want to specifically show that detail, I wouldn't use a diffuser because it can be distracting. So why do we take photographs? Well, they provide such an excellent record of the patient with regards to how much teeth they show on smiling, their skeletal pattern, their vertical dimensions, the soft tissue envelope in which the teeth sit. You can see as much as there is to be seen with a good set of photographs. In the frontal photograph, you can see the condition of the teeth. You can see in the buccal photographs the buccal occlusion, as well as any areas of oral hygiene that could be improved. And the occlusal views give you a plan view of the teeth, so any spacing or crowding can be seen and assessed well. And it allows us to communicate clinical techniques with our colleagues. A picture really does paint 1,000 words, and so what you can do here is you can see what you want the colleague that you're trying to communicate this technique to do exactly in the lab or in the clinic when you try and pass that information on. And then we've done this on multiple occasions for various clinical tips that we've written up and had published. And it also allows you to appreciate the progress that you've made. In orthodontics especially, it's impossible, unless you've got a photographic memory, to remember exactly what the patient looked like the previous time that you saw them. So the only way to know if you're getting closer to the finish line with the mechanics that you've used is by taking good quality photographs. And there's also, I think there needs to be some argument made to appreciate the art in what we do. And I think we should be proud of what we do as dentists, because it is really a step out of the ordinary. And if you look close enough, there is an artistic appreciation to be had for so much of what we do as orthodontists and dentists. And I think it's worth capturing that. So let's talk about extraoral photographs. So those are the settings that we've spoken about: the shutter speed, the f number for the aperture, and the ISO. And that's what you need to use, or at least that's your starting point for extraoral photographs. You want a photograph of the patient in repose, at rest, and you want a photograph of the patient smiling. And you want them to be looking directly into the lens of the camera. And that's what you say to the patient. You say, I want you to look nice and relaxed into the lens of the camera, and you take the first photograph. And then you don't move the camera away from your face, because if you've set things up properly and you know that the settings have worked effectively, then you should be able to move directly onto the second photograph. And that means everything else remains the same except for the smile. And the three-quarter view, there's no criteria or guidance as to how much the patient needs to be turned around for a three-quarter view, but you need to be able to see some of the side of the face that is further from the camera. And you want to be consistent. So try, if you're going to get an eye's width shown every time, get an eye's width shown every time. And that way, if you show a succession of cases, they all look as identical in terms of the composition as possible. And in the profile, you want the patient to be looking in natural head posture. So you want them to be looking at a point distant on the horizon. So they're holding their head the way that they ordinarily hold it in their day-to-day lives. And that gives you the truest appreciation of their skeletal pattern in the vertical and in the anteroposterior dimension. And some individuals like to take what's called an animated three-quarters photograph. And that's essentially a three-quarters photograph where you get the patient to turn only their eyes to the camera. And it gives a more, I guess the word animated is probably the best way to describe it. It's like a school photo kind of photograph. So a word about the Duchenne smile. So people often ask, especially when you're working with moody teenagers, how do you get them to smile? And that's a really difficult thing to do, because the temptation is to try and make them laugh by saying something funny or get mum to pull a funny face in the corner. But the trouble is that can actually genuinely make the patient laugh. And what you then get is a true smile as an expression of positive emotion, which is called a Duchenne smile. And in a Duchenne smile, the muscles act differently to what they do in a posed smile, which is what you see on the right. And that's the smile that we treat in dentistry. In a Duchenne smile, the muscles around the eye and the lips, they're more active. So the patient tends to squint a little bit more, and they show more gingivae as well. The trouble with a Duchenne smile is that it's not reproducible unless you're able to make the patient laugh every single time. But when you do make a patient laugh or smile in this way, the muscles are uncontrolled, so you can't have reproducible photographs. So when the patient can't smile or doesn't know how to smile, you've almost got to teach them how to do a posed smile. It's a life skill, and it's something that they'll thank you for the rest of their lives. But it's the only way that you can get reproducible photographs. And it's not worth trying to make them laugh, because it's not reproducible. It makes the muscles do things that you can't always replicate. So how can we optimize extraoral photographs? What can we do to make them better? Well, we can use what's called a speed light or an off-camera flash. It's sometimes called a slave flash. This is an additional flash that talks to the flash on the camera. So this goes off when the flash on your camera goes off. And what you do is you position this behind the patient. And you position it behind the patient because it produces loads of light behind the patient. And so when you take the photograph, it overexposes the background and makes it absolutely white. And it gives you a professional quality to the photograph that you don't necessarily get when you've got a non-white colored background. So I hope you all agree that the photo on the right is better than the photo on the left. And often a thing or a troublesome feature of many photographs is red eye. And essentially what red eye is the eyes are immensely reflective. And what happens is light travels through the eye to the retina, and the blood vessels in the retina obviously are red, and they are reflected back into the lens of the camera. And there's a couple of things that you can do to manage this. You can either get the pupils to constrict before you take the photograph by just pressing the flash on its own and then letting it whir up and then taking the photograph. And that causes the pupils to constrict, and so they don't reflect as much light back. You can make sure the ambient light in the clinic is a bit brighter, so dimly lit rooms tend to get more red eye. And a final thing you can do is, if you're taking a photograph where the overhead light for the chair is nearby, you can just shine that near to the direction of the patient. Make sure you don't get it in the photograph, and that will make the eyes constrict and diminish the red eye. You can use post features as well, software to remove red eye, but that's onerous because you've got to do it for every photograph. A word of caution about using slave flashes: if you overdo it, it overexposes the subject as well, and then what you get is a blurring between the background and the subject, and it just looks overdone. So you've got to be careful with how much you use that and where you get the patient to stand relative to the slave flash in the background and the flash on the camera in the foreground. And the other thing that you can do, and I learned this by reading about and looking at portrait photographers, is you can modify the direction of the light and modify the intensity of the light. So this is what we normally do when we take a portrait photograph. We point the ring flash at the patient, and what this tends to do is highlight the sort of shine in the patient's face and all the pores and fine detail of the texture of the skin, and that can be less flattering and not so pleasant. However, what ring flashes do is they give you these little white dots in the eye of the patient, and that can be quite a nice thing, and it looks pleasant. But what can we do to attenuate the problems with the shine and the skin? Well, you can bounce the flash, the ring flash, off the ceiling. So you just have to unhook it from the camera, point it at the ceiling, and what happens is you soften the light, and you can get a far more flattering photograph here, and all the detail of the pores and the shine on the skin has been removed. But because the flash is pointed at the ceiling, you get shadows underneath. So under the patient's chin and mandible, you get shadows, which itself can be unflattering. So a better solution is to take the ring flash off of the camera and point it behind you. So the light will bounce off the wall behind you. And really there needs to be a wall behind you rather than a big corridor, because that'll just attenuate the flash too much and the picture will be dark. The light bounces off the wall behind you and it more uniformly lights the patient's face. So you need to be wary of the dimensions of the room that you're working in. You need the wall reasonably close behind you, but this is the improvement that you can achieve. So directed at the subject on the left, at the ceiling in the middle, and behind the photographer on the right. And you can see how it's a definite improvement there, and it gives you a far more flattering extraoral image. And you can see that illustrated with the 3/4 view and in the smiling photograph as well. So let's talk now about intraoral photographs. Again, the ISO stays at 100. The shutter speed stays fast at 1/200th of a second, but what you do is change the aperture, and the higher the f number, the smaller the aperture, and the more of the image that's in focus. And you might want to turn the aperture, so open up the aperture, turn the f number down when you're taking the mirror shots, and we'll talk a bit more about that in a second. So in the frontal view, you want the occlusal plane to be level, and you want good vertical retraction. So often you get two sizes of retractors. You get small ones and you get larger ones. And on the larger ones, you have a side where there's, which will give you good vertical retraction, and a side which is longer horizontally, and that will give you good horizontal retraction. So for the frontal photograph, you want the two larger retractors in the vertical dimension. So you've got good vertical retraction of all the soft tissues away from the teeth, and you can see as far back as possible into the mouth, and the occlusal plane is level. For the buccal shots, you want the horizontal retractor on the working side and the vertically large retractor on the non-working side, and so you've got good vertical retraction of the tissues and the mucosa away from the teeth. And it's important to have this retractor, the one that's not on the side that you're taking the picture, away from the teeth so you don't see it in the shot. And you want to pull reasonably firmly on the retractor that's on the working side so you can see the buccal occlusion in detail. And soft tissues are sort of slightly thixotropic, which means that if you pull firmly, they kind of resist you. However, if you slowly pull over a prolonged time, they tend to give and be more malleable. And similar for the left buccal. In the occlusal photograph, a common error is to see the retractors behind the upper incisors, and we'll talk about how to prevent that. But you want to see the entire dentition in plan view and as little of the retractors as possible. And similarly for the lower occlusal, you want the patient to either sit their tongue beneath the occlusal surfaces of the teeth, which some patients do reflexively, and if they can't do that, you get them to tuck their tongue behind the mirror and see as much of the teeth as possible. So intraoral photographs are all about retraction and retraction techniques, so you need to counsel and educate your assistant to do this as well as possible. And you want to keep the sequence of photographs exactly the same so that the assistant knows exactly what you're going to do next and knows exactly what's required of them. And you want maximal control of the soft tissues. And it's all about moving things out and away rather than back, which is what the temptation often is with the retractors. So here we're going to see how you retract for a frontal photograph. So as the video is playing, you can see that the temptation of the assistant is to put the retractors in and then pull back. But the soft tissues aren't under the control of the retractor there. So what you do is get the patient to open slightly so that the soft tissues are slack, and you get the soft tissues fully under the control of the retractors and then pull them forward. So just to see that again, the assistant should really get the lips under the control of the retractors by themselves, and they can do that with enough practice. It's all about keeping the mouth slightly open and encouraging the lips to sit fully in the retractors and then pull forwards. So you've got good vertical retraction. For the buccal shots, one side has to be flipped over to the horizontally larger retractor. And you can see that the temptation of the assistant is to pull back. And what you want to do is flick that retractor out. So like I mentioned on one of the previous slides, you don't see the retractor behind the teeth in that buccal shot. And patients love having their photographs taken. You can see how pleased this patient is with the photographs that are being taken of her. And it's a similar thing on the left buccal as well. So you'll see that once the retractors are placed in, the temptation will be to get the patient to move around by pulling the retractor around. But what you want is to bring it forward like that, so it's not in the photograph and not behind the teeth in the buccal shot. The upper occlusal is probably the most difficult for the assistant because they really can't see what they're doing. So you place the mirror in and you ask the assistant to not pull back, but hold the mirrors vertically and forwards. And there's a tendency sometimes to overcorrect like that and tilt them forwards. But what you want them is perpendicular to the mirror, so as little of the retractor is seen in the mirror as possible. Perpendicular to the mirror, and the lip should be brought forwards and out. And the lower occlusal is actually one of the easier photographs to retract for, because the assistant can clearly see that the lip's out the way and they can clearly see what they're doing. But again, the technique is to bring things out, and the mirror goes in. The patient's asked to bring their chin up as high as possible, and you get a plan view of the teeth. So this is the tricky photograph, and this is a common error. You see the retractors behind the upper incisors frequently like this, and it looks less than ideal. So there's a couple of things that we need to take away from this slide. And the first thing is that these photographs look different in their sort of quality and the color, the temperature of the colors in these photographs. And that's because these were taken on a Nikon camera. And the photographs that you can take on a Canon or that you can take on a Nikon tend to have a different feel about them. And it's due to the color, the temperature of the colors that each produces. And you can either have a preference for one or a preference for the other, but I feel that Nikon photographs tend to look slightly aged, and so I prefer the ones that the Canon provides. And here's how not to do it. So you can see that the retractors are being pulled back, and because they're being pulled back, they're directly behind the teeth in the mirror when you take the photograph. Instead, what you want to do is pull forwards, and you can see the difference in the patient's lip between doing it incorrectly and doing it correctly. When it was done correctly, it looks like they've had gallons of collagen filler pumped into their lip, and that's what it wants to look like, so that you've got the retractor out of the way of the teeth and you get a good photograph. And often people say that photographs are onerous and take a long time to take and complete, but really once your assistant and nurse is well trained, once the patient's well trained, they can be taken really efficiently. So you can see here what I've done is I've given the suction to the patient, because saliva ruins photographs, and the patient knows to hold the suction in front of them, and I take the suction from them intermittently and pass it back to them. So I'm not leaning over them to get the suction and putting it back. The assistant knows exactly what they're doing and knows exactly how to get the soft tissues under control with the retractors. So I'm not having to move the retractor on the non-working side to get it out of the way of the teeth. The suction's at hand and I can take the photographs quickly and efficiently. I take the same sequence of photographs every time, so the assistant knows exactly what I'm going to do next. And the mirror's already warmed and ready to go, so I'm not waiting for that to be heated as well. The upper lip is retracted, the mirror goes in one corner at a time, so you don't rip the lips open as you put it in. And it's a long mirror, because smaller ones will often result in you taking photographs of your fingers because they'll be closer to the teeth. So a longer mirror is better because it allows you to get your fingers and thumbs out of the way. And that whole process took 1 minute and 12 seconds. So if everyone's well versed and if it's a slick and consistently performed routine, it can be done really quickly. So the common mistakes that are found with photographs are often saliva, and that can really diminish the quality of photographs, because what saliva does is it distracts you when you're looking at the teeth. And what tends to happen is your eye is drawn to the saliva rather than what's going on and what you want to see in the picture and the image. And the easiest way to get around that is to make sure that you suction the saliva out of the way and get the patient to hold the suction so that it's ready to go and you're not having to try and reach and grab for it. Some people like to educate the patient to try and swallow all the saliva in their mouth, but that never really does it adequately. So you need to suction all the saliva out to make sure things are absolutely bone dry. And then if on top of that you use a diffuser, things look even more drier and professional. Like we saw in the retractor videos, when you've got retractors behind the teeth, it just tends to look a bit amateur and not so professional. So you want to apply the tips that we've just discussed there to get the retractors away from the teeth. So you've got mucosa, the mucosa of the lip behind the teeth there, and not retractors, which can be distracting. And if the retractors aren't used properly, what tends to happen is you get the lips overlying the teeth, and again, you don't get a full picture of what you want to see and all the detail that you want to capture. And I guess it's worth commenting a little bit on dental photography and legislation. The legislation has changed in terms of the GDPR and UK data protection law, and these changes came about in 2018. And they're really complex, and you sort of need to be a lawyer to understand them in detail. But the real simple takeaways that we need to abide by is when you take consent for photographs, especially if you're planning on using them on social media, you need to tell the patient exactly what you're going to do with them and gain their explicit consent for what you're going to do. So if you're going to say, or if you're going to use them for social media, you say, well, I'm going to put your photographs on social media. And that could mean that they can be seen by anybody. Would you be happy for that? And if they are happy for that, in the consent, you say social media use or placed on platforms such as Facebook and Instagram, and be very specific so they know exactly what they're consenting to. And you've got to be as clear as possible on that front. And patients have a right to access the photographs that we take of them, but they need to be able to ask for these photographs in an explicit way, not just verbally. And we need to be able to provide these to them when they do ask for them. And patients frequently do. And it's not necessarily a bad thing, because what it allows you to do is demonstrate what you've done for this patient over the months and possibly years that you've seen them and what you've achieved with your orthodontics or your dentistry. And you've got to keep your photos secure. So on password protected memory cards, or ideally on a password protected server that's securely backed up. So the key points of this presentation was that excellent photographs really do facilitate excellent patient care. And taking good quality photographs is all about optimizing light. And we've learned a little bit about the exposure triangle, the ISO, the shutter speed, and the aperture. But really what we change more than anything is the aperture. And when we control where light's coming from, whether that's above the patient, behind the photographer, we can get a better quality photograph that reduces some of the reflections and the texture of the skin, makes things look more flattering. Retraction is really what's essential for good quality intraoral photographs. And you've got to counsel and educate your assistant to do that as well as possible. And once they're well counseled in how to do that, you get absolutely excellent photographs every single time. And it becomes a breeze to do it as quickly as possible. And as we saw, it can be done in under 2 minutes. So I'd like to acknowledge all the people that really helped in the making of this presentation. I'd like to acknowledge Mr. Morris, who was really my introduction into orthodontics and orthodontic photography. And I've learned an awful lot about orthodontics from him, and I owe him a great debt of gratitude there. I'd also like to thank my nurses, Chantel Cole, who reluctantly consented to having her photographs used, but consented she did, and also Gemma Ward as well, who you saw having her cheeks pulled very gently into the right directions to help demonstrate how good retraction is done. And also Angela Witchell, who was the retractor in that photograph as well. I'd like to thank Jonathan Sandler, who I've learned an awful lot about photography from, as well as Trevor Hodge for some of the photographs that he's provided for this presentation. And if you've got any questions at all, I'll be more than happy to answer them. It's over to you, Mr. Morris.
Okay. Well, thank you, Naeem. That was very informative and clear presentation. Tons of useful tips for all of us to take on board. So thank you again. Well, we've got a 15-minute sort of question and answer session. So Fatima, what audience questions have developed from Naeem's presentation?
Yes, we've had a few questions. Oh, they're all coming in now. Okay, I'll just start in order of how they've come in. Your first question, okay, is from Mohammed Fauzi. What is the name of the brand for the ring flash diffuser you use?
Yeah, that's a good point. If you search diffuser, Canon ring flash diffuser, there's a website, and it's probably the third entry on Google. There's only one manufacturer in the UK that really does a ring flash diffuser. I can bring it up again. It sounds like a sort of one-man band operation, and it costs £60. I can't remember exactly the name, but it is literally the third entry on Google for ring flash diffusers. It's almost called something like I don't know, like, no, I really can't remember, but it's really easily found. Now, what's really interesting about this diffuser here, so £60, right, made in Great Britain by some bloke in his shed. You can, the equivalent American thing, which I do know the name of because it's actually quite a good name, it's called the Flash Cap with a K. That's $500, and it does exactly the same thing as that. And this was 60 quid. And I think if you already take fantastic photographs, this has the potential to make them just maybe 5% better. But the more important things are the composition and the exposure. I hope that helps.
Okay, sorry. Yeah, another question from Roshishkesh Bhuchpal. Please guide for the patient position while we take maxillary and mandibular occlusal view mirror photographs.
Yeah, sure, of course. So let's go on to these here. So perhaps the thing to do, the best thing to do, right, we're leaning on technology here, Fatima. I know your heart's in your mouth. Okay, the whole thing can crash. And I'm awfully sorry if that's the case. But if we go for it. Okay, so you have the patient seated just like you normally do, okay, and you place the mirror into the patient's mouth like that. And then what you want to do is not that. What you want to do, if I can pause it at the right time. So, okay, let's start with the mandibular, okay? So you get the patient to open wide, you get the retractors in the right place, you put the mirror in, and the key with the mandibular photograph is to get the patient to put their chin up as high as possible. So you get them to look at the wall behind them. And some patients, when asked to look at the wall behind them, will move just their eyes. So obviously tell them to move their entire head and try and look at the wall behind them. And then what you do is you try and get that mirror as close to vertical as possible. And you try and get the mirror behind the last standing molar. Okay, and when you take the photograph, you're usually leaning, not leaning, but you're touching the retromolar region, and you just lift it away from the retromolar region, and then you take the mandibular occlusal photograph. And what that does is it gives you a plan view of all the teeth. So it's all about having the patient as wide open as possible. So you get them to open as wide as possible, you position the mirror, you lift it up slightly, you hold the camera just as you're about to take the photograph, you say open twice as wide, and what you can usually get is another 5 millimeters of opening, and that gives you the photograph that you need. Now for the upper occlusal, you put the retractors in like we discussed, you put the mirror in, and what you do is you get the patient to open as wide as they possibly can. So let's get the retractors in the right place. Eventually. Okay, good. And at that point, I didn't get Gemma to do it, but at that point, you've got to get the patient to open as wide as possible. And then you get your camera in position. And if you need to see a better plan view of the teeth, you get the patient to put their chin down. Okay, so you can see more of a plan view of the teeth in the mirror there. I hope that helps.
Okay, we have a question from Basma Nabil. Do you prefer ring flash over twin?
Yeah, I think so. I've kept it simple here for a couple of reasons. I think what you want to be able to do is take good quality, consistent photographs yourself, and also be able to pass that information on to any assistants or nurses that might be taking photographs for you. You might have nurse-led record clinics, and all these tips are relatively easy to apply. I think a twin flash often gives you better illumination. Now, when you use a twin flash with a diffuser, you get loads of diffuse light, which gives you an absolutely gorgeous quality to your photographs. The trouble, however, is that they're more expensive, and also because you can move them around, and you should move them around when you're taking the different intraoral photographs, there's more moving parts and there's more things to play around with, so it's harder to then teach another person how to do that. So I think with a twin flash, you can probably get a more exemplary quality of photograph, but it's more expensive and it's difficult to teach, and therefore less reproducible by other people. I'll get Gemma off the screen. She'll be mortified. How about that?
Okay, thank you. I think we have a question from our very own Robert Crawford, FGS board member. What are your thoughts on using buckle mirrors?
Yeah, I think again, I think buckle mirrors give you the best perception, the best idea of what the buccal occlusion is, all the way to the last standing molar. I was having a discussion about this just today, actually. I think that's the gold standard, isn't it? And if you can use them well and use them properly, they'll give you a better buccal shot, a true buccal shot every time. So if you're aiming for absolute perfection, yeah, use buccal mirrors. I think that is the way to go. But for the reasons that I outlined to the previous questioner, I think you can get very good quality photographs without the use of buccal mirrors, but they are the gold standard.
Okay, thank you. Russell Hathaway wants to know, do you have any tips for photographing soft tissues, red patches and white patches?
Yeah, you know, so the thing that the diffuser really excels in is soft tissues, actually, because it makes those reflections off of the soft tissues more diffuse, and that's really the distracting thing. That's what attenuates the detail in the photograph, these reflections on the soft tissues here. So if I was doing a lot of soft tissue work, which I'm not, that's where you'd really want to use a diffuser. So you can use loads of light, get the soft tissues as dry as possible, and then use a diffuser so you can pick up the quality of and by quality I mean like the texture of those soft tissues as much as possible. And the other thing you need to bear in mind with soft tissue photographs is I think some people get very caught up in trying to take a photograph of the very small part of the soft tissue that they're working on. So you know, if they've done a gingivectomy or something like that, they'll focus on the teeth that they've performed that gingivectomy on, and the quality of the macro lens is often almost invariably so good that you can take a photograph that is not so zoomed in on that one particular detail and then crop it to the area of interest. And what that means is that you're more likely to capture absolutely everything that you want and then crop it down and get rid of the extraneous information that you don't need, rather than try and take a photograph of exactly what you want. And then if things aren't aligned properly, or you feel like you've just missed a bit of detail, you've lost your opportunity because that information was never captured in the first place. And if you're really picky about having all the information from your photographs, then you can change the settings on your camera so you get a RAW file as well as a JPEG every time you take a photograph. And because you've got a RAW file, if the photo's not turned out absolutely brilliantly in terms of exposure, you've got more capacity to change that in post-production and make it brighter, and account for some of the issues that you would have with not having the exposure right in the first place. But if you get it right the first time, then you don't need to bother doing that. But a RAW file gives you that lateral ability, that sort of option.
Okay, thank you. Nuraini Mohammed Noor has asked, how do you take the picture of lesion, for example, for an ulcer?
How do you take a picture of a lesion, for example, an ulcer?
Yeah.
Well, I would say that you take a picture of a lesion in the same way that you take a picture of anything else intraorally, and that is you want to have it dry, you want to have it in focus. And personally, what I would do is have some kind of scale next to it. So if you have a ruler, hold a ruler up to the lesion in the photograph, so there's an accurate depiction of how big that lesion is, and whether over the passage of time it's gotten larger or smaller, and you can document that. But I wouldn't particularly do much differently to what I've described here. I'd just make sure that there's some kind of record of its dimension.
Okay, thank you. Simran wants to know, would you recommend a ring flash over a twin flash?
I think I would, especially if you're getting into dental photography. I think because there's technology progresses so quickly, and one of the things that we've seen come about and used more often are twin flashes. And as I say, they probably do give you a more exemplary image, but a ring flash will give you pretty 95% of the way there. And if you're just getting into it, and if, for example, cost is a barrier to entry, right? If you think, well, you know, there's a lot of money to spend, buying a twin flash and the latest mirrorless camera will cost you a fortune, and getting a far cheaper camera body, a good lens and a good ring flash will be far cheaper and will get you about 95% of the way there. And especially if you're going to be using this camera and giving it to assistants, or you're going to be leaving it at your workplace and there's a possibility that somebody else could use it who's not so careful with it. You want to be going for something that you're going to use consistently and you're not going to be worried about damaging, because wear and tear will happen. And on that point, a lot of people also ask about mirrorless cameras. And mirrorless cameras, they're quite clever, and they offer you this ability to look at what part of the image is in focus without just using your eye, but electronically. But I think with practice, you can do that with a DSLR, and you don't necessarily need a mirrorless camera to do that. Well, there's a few advantages, but one of the principal advantages of a mirrorless camera is if you need to get down to the gym and you've got weak arms, the mirrorless cameras are far, far lighter. But I would say just buy a DSLR and get your biceps bigger.
Okay. Noor Nadia Zakaria asks, do you prefer using the cheek retractor or buccal mirror for buccal shots?
I use the cheek retractor. I use the cheek retractor simply because it's easier to get the assistant to get it right every time. And the other thing I like to do is, because taking photographs is an additional thing, right? It's an additional procedure that you have to do for the patient. So there's one of two ways, I guess, you could approach this, right? You could either have the conviction that you're going to take a sequence of photographs for every single patient, every time you see them, irrespective of the appointment or the nature of the appointment, and that is just what you do. And that's one way of solving that problem, and it's a very effective way of solving that problem. The other way to do it is to completely minimize the barriers to you taking a photograph on the clinic. And if that means having fewer moving parts, and that means having the assistant, irrespective of which assistant it is, being able to consistently assist you as effectively as possible, then that means doing that by having the simplest, most effective option.
Okay, I think we have, hang on a second, just coming. Oh, another question from Robert Crawford, although I think you may have already answered this. Will mirrorless replace DSLR cameras in the dental photography in the future?
Yeah, probably. I think as technology moves on, yeah, definitely. Yeah, I once things get sufficiently cheap enough, there's little reason to move on to that next improvement in technology. So I think eventually, yeah, probably. But for now, it's not like we're taking photographs with our DSLRs and the flash setups that we have at the moment, and we're just begging for improvements, thinking, oh, if only there was more focus, if only there was more detail. I think we can take very good photographs with, as we've seen here, decade-old technology. So yeah, with the passage of time and the cheapening of equipment, yeah, probably. But for now, I don't think you have to necessarily be an early adopter.
Okay, Noor Zakaria asks, what do you think of smartphone photography with an accessory that resembles trend flash? Many people are using mobile phones in my region.
Yeah, it's not as good. It's not as good for various reasons. Smartphones you can't control the exposure on a smartphone in any way as well and with as much precision as you can on a proper digital camera. The smartphones were never set up to take dental photographs because that's macro photography, and that's why we use a macro lens. Now, smartphones can have a macro feature, they can have very clever software settings that can account for the ambient light and all the other features of the exposure triangle that we spoke about in the presentation, but it's not as good, and it can't be as good. Now, the other thing you have to bear in mind is the patient's perception. So if you're in a clinical setting and the dentist produces what looks like a fit for purpose camera assembly and they're taking clinical photographs, then that gives a very different perception to if they whip out an iPhone, irrespective of what kind of flash system they've then put onto that. So I think that does have an impact, and I think we should be conscious of that. So I would always go for a proper camera system and assembly.
Okay, and Mohammed Umar wants to know, I'm doing a research project involving parents of preschool children taking intraoral photos with smartphones to send us to screen for early childhood caries. Do you suggest something more to improve the quality of photos taken with common smartphone cameras?
I guess if your research project is getting the patient to take photographs or the patient's parent to take photographs, then you're sort of limited in what's available to you. I think a bad photograph, as long as it doesn't give you an inaccurate representation, or probably more accurately, a misleading representation of the teeth. So a bad photograph which makes it appear as if there's caries when there isn't, is worse than no photograph at all. However, a bad photograph or a less than ideal photograph is probably better than no photograph. And if that means that the patient uses their smartphone to take photographs of their teeth, and you use that for almost a different purpose, aren't you? You're using it as a screening tool. And a screening tool is not designed to diagnose, it's designed to screen. And if that means you pick up more caries, then I think that's very, very worthwhile. And in that particular instance, if I'm understanding the heart of your question correctly, what you want to do is to put the least imposition on that parent as possible. And if that means that they can use the camera phone that they've got in their pocket to take photos of their child's teeth as quickly as possible without having to think about it, get something additional, get something extra, then I think that's probably an overall benefit than having a higher quality photograph when all you're trying to do is screen. So good luck with your research projects, and they're my thoughts really. You want the least imposition on the parent as possible and get the most benefit for that.
We've got a very valid question from Fiona Elwood. Isn't there a number of legal obligations to be considered when utilizing smartphones and more data ownership?
Yeah, definitely. I think the other thing about a smartphone is it's connected to the internet. So a lot of us, knowingly or unknowingly, have signed up to automatic uploads of our photographs to the cloud, right? So if you take a photograph of a patient, that photograph is then uploaded onto your own personal Google Cloud or iCloud or OneDrive, whatever it might be. And so whether you like it or not, I think perhaps unsuspectingly, you've kind of stored the patient's photographs in a location that perhaps wasn't the ideal place for them, or at least transferred them maybe from one country to a server somewhere in a different country. And did they necessarily consent for that? So I think that's another reason. Yeah, you've got to be very careful with photographs taken on smartphones. At that point, you might say, well, what if I use a smartphone just for the clinic? And if you're going to pay for a smartphone just for the clinic, you might as well spend the £700 or £800 and get a proper camera setup that will take far better pictures and have far fewer medico, legal and data implications.
Okay, and I'm going to take one last question before I pass over to David. For reproducibility, do you prefer using the manual or electronic through the lens flash setting for the ring or twin flash?
So I use the electronic through the lens flash setting. Yeah, I think technology is awfully clever, and it's far cleverer than I am. So I let the camera do some of the hard work there, and I let it control that part of the exposure. So I don't mess around with the flash. I use the through the lens flash setting. What I control is the aperture. So if the exposure isn't right, that's the first thing I'll control. Because for example, on the extra-raw photograph, the worst that can happen really is you put the f-stop quite low and you get a nice bokeh effect, and the background of the patient or the hair in the background is just slightly more blurred than the smile at the front. And actually, if anything, it can look even more appealing. And with the intraoral photographs, well, the photographs that suffers most when you try and control the exposure by putting the f-stop down is the frontal inecclusion, because what you then tend to have is the incisors in focus, and then as you go further back in the photograph, the molars and the premolars tend to lose focus. So that does suffer when you put the f-stop down. However, you can set up the autofocus so that it's focusing at teeth at midpoint in the arch, like the canine or the first premolar, and that way you give the photograph every chance of capturing as many teeth in sharp focus as possible. So I think you should lean on technology when it can help you and when it can give you good and consistent results. And when you have to take things into your own hands and do things manually, you should do and alter the things that are going to have the least compromise to the photograph that you get at the end.
Thank you so much, Naeem. David, back to you.
Okay, thanks, Naeem. That's very thorough answers there. I'm sure the audience appreciated that. So before I bring the shutter down, there's only one more pun, I promise, on this evening's excellent session. Thank you to our audience for attending, even though I can't see any of you, and for your insightful questions. My thanks again to Naeem for a really enjoyable talk, which gave us a number of points to reflect upon. I'd also like to thank our webinar coordinator and the voice you're hearing in the background there, our Faculty Head of Education, Fatima Bobulia, for organising tonight's session so well. Can I remind everybody that all forthcoming as well as previously presented webinars can be found on the faculty website. If you just click on the Our Dental Webinar tab on the right-hand side of the screen, where you'll find the full list and where you can register for any upcoming ones as well. So the next webinar is on June the 6th at 6 o'clock, and that's entitled Achieving Success in Endodontics for the General Dental Practitioner. And the presenters on that evening are Kasim Butt and Oliver Jones. And then following that, the next webinar is on September 5th, when Jag Danda will be discussing the utilization of extended reality in medical, surgical, and dental education and its applications in global health. It's promised to be both a futuristic and thought-provoking presentation. So that's all, folks. We hope you enjoyed it, and we'll encourage you to register for future faculty webinars throughout 2023 and beyond. It just gives me the opportunity to hope you enjoy the rest of your evening, and goodbye from us. Good night.